Next part of the seminar, we will start with a panel discussion. So we will get to explore this topic a bit more deeper by inviting our multidisciplinary experts to our panel discussion. We have Dr. Jennifer Bombish, who is an expert in gerontological nursing, a professor, and a CIHR chair in sex and gender science relating to the dynamics of caregiving in an aging society at the University of British Columbia's School of Nursing. We have Dr. Amanda Grenier, who's a social gerontologist. She's a professor at the Factor in Wattash, Faculty of Social Work at the University of Toronto, the Norman and Honey Chipper Chair in the Gerontological Social Work, and a senior scientist at the Rotman Research Institute at Baycrest Center for Geriatric Care. We also have Dr. Habib Chaudhary, who's an environmental gerontologist, a professor and chair at the Department of Gerontology, and an associate director in the Gerontological Research Center at the Simon Fraser University. He's also affiliated with the Center for Research on Personhood and Dementia and the Center for Advancing Health Outcomes at the University of British Columbia. And we have Dr. Whitney Burda. She's an expert in health services organization and management science. And as you may recall, she's also the co-coordinator of the seminar series based at the Institute of Health Policy Management and Evaluation at the University of Toronto. Thank you all for joining us today. So I want to first start with some reflections that we have on Heather's seminar. We will first go around our virtual table and ask our esteemed panel to first share their thoughts about Heather's seminar and then ask questions that they might have of Heather. And after the panel has shared their thoughts and asked their questions, I will then call upon each of the panel members to ask more specific questions pertaining to their area of expertise. So let's get started and start with Jennifer. Jennifer, you're the co-author to Heather's article on incivility in long-term care. Would you like to share some of your thoughts on the presentation and ask Heather a question?
Absolutely. I think, I have been a nurse now for almost 30 years, and I started my career working in long-term care, and that's really as a nurse where I feel at home and where I prefer to work. And so when Heather started doing this research, well into my career, all of it resonated so much and just gave me flashbacks to those night shifts and evening shifts and that huge anxiety as a new grad working in a long-term care home where I was often the team leader of people, care aides who had way more experience than I had, working with nurses who had particular ideas about a BSN prepared nurse, because that was just at a period of time when we had more nurses graduating with their bachelor's degree than were diploma prepared. And so it brought a lot back. And it was sad for me that things really haven't changed. And I think that part of this is also around the context of work, the staffing levels, the under-resourcing in this sector. One of the things that I absolutely love about this project, and that we rarely see in research anywhere, is this incredible research industry partnership that unfolded over the course. And to see the toolkit that Heather has created, and I don't think it comes across when she shares it how complex that was, because it involved working with multiple unions who are involved in BC's long-term care sector. They all sat at the table together, bringing together SafeCare BC, other employer types of organizations to come together and agree on the content that would be going into this toolkit that's now available online. And so sometimes we hear it takes, 17 years or 20 years from research to go from sort of doing the research to getting into practice. And here we see very much a project that very quickly transferred from doing the research to having tangible tools online that people can use. And I know Heather has done so many workshops around British Columbia with Rhonda, who I think needs to be acknowledged as well. So I guess my question for Heather is just, how did you organize? What is that saying about, organizing cats in business, or like trying to get everybody together on the same page, working together cohesively towards the shared goal, really around improving workplace civility at the actual point of care? And Heather, maybe you could comment a bit. Oh, herding cats. Thanks, Amanda. Yeah. I learned that a long time ago from Heather Lastinger at Western University. Um, like how, what were some of the key things that kept that group coming together, built their commitment to the project? And what work did you need to do as the project lead to really make that bridge from research to practice happen in such a really relatively efficient and quick way?
Oh, thanks, Jennifer. And I think, can everyone hear me okay? I know there were maybe some issues before. Yeah, okay. I think it really speaks to the importance of having those partners on board from the get-go. So we really made this concerted effort, and Jennifer and I sort of sat down and thought about, like, who do we need to have at the table, and extending out to those organizations, inviting folks to that initial meeting, and to really have it be a bit of a exploration and discovery meeting, and just, hey, this is what we're seeing, this is what we're hearing. And I think because it's an issue that really unites a lot of folks in the sector, because, as you say, Jennifer, you think back over your 30 years, and I can think when I was on the front lines as well at the start of my career, and experiencing similar things. So I think it really speaks to that, and bringing people on right at the start, and then really engaging them in the entire process. So it wasn't that we just brought the folks on to do the toolkit. We had engaged with them, and we had this advisory committee over the course of the research. And so being able to say, here's the findings, what are some ways that we might present this? And it was really kind of that brainstorming where folks are like, what? It would be really great if there was something online. Is there, how do we collate all these resources? How do we put all of this in one spot? So really, kudos to them. It was very much that team approach. So starting early and really keeping those partners engaged and close at hand.
Great, thank you for your response, Heather. And I think this, with Heather's response, it closely relates to Whitney's work. So I was wondering if Whitney, you would like to go next with your thoughts and questions?
Oh, sure. And in fact, I think one of my comments has a fair bit to do with kind of the toolkit and the context in which it was developed in the broader context. I mean, thank you so much, Heather. This is amazing, amazing work. It really resonates with me. I kept thinking about this overarching theme that seemed to emerge as you were speaking around power, right? And power differentials. And this, these systemic structural factors that, are pervasive, particularly in this sector of healthcare. I mean, this is healthcare, the healthcare system, at least in Canada and many Western countries, has historically privileged other sectors, right? Particularly favoring acute care and so on. And so we have this issue around long-term care as a sector. We have the population of older people who, dare I say, are perhaps undervalued in some societies, and in Western societies in particular. There's a workforce that cares for this population who are also undervalued. And in addition, as you mentioned, they derive from, racialized groups, predominantly women. So I really love the toolkit, and I appreciated what its function and promise is. And I wondered also if we can address, can you develop a toolkit that addresses societal incivility? I mean, frankly, in part, that's what we're talking about. And I'm not to be frivolous. I mean, this is, you're talking about the context of organizations, facilities. They're situated in these broader contexts that continue to persistently, right, reinforce this this pervasive undervaluing, disproportionate power, right, allocation, and so on. Not a problem we can solve today, but certainly something that your work is beginning to address, which is marvelous. And then I really would like to talk as part of the panel, I think more broadly, about, and hear from you in particular, about how you see, this is one of the first sessions that has focused on things psychosocial, kind of facets of the work environment that's psychosocial. Other prior sessions have focused on the influence of the kind of physical, tangible features of work environments. I wonder how you see these interrelating. For example, are there physical features of nursing home environments that might reinforce or be particularly tolerant of um, uh, uncivil behavior amongst staff and residents and residents and residents?
So I actually might toss this one over to Habib to sort of gather his thoughts or garner his thoughts around the role of the physical environment.
Thank you, Heather, for the wonderful presentation. Really enjoyed it. And I think before I respond to the question, I think that's what I was planning to do that anyway, to address the environmental context and how that is relevant. I do want to acknowledge the importance of what you presented, Heather. I think we talk about, if you look at the literature in long-term care, there's a great deal of emphasis on the quality of life of the residents. And I wonder whether anybody has comparatively analyzed the amount of work focusing on residents versus staff. And we know that staff, if you want to have good quality of life for residents, you have to have good quality of life for the staff, which means a lot, and which we know because of the pandemic in particular about being understaffed, overworked, underpaid, and all that. So it's a really important topic that we're addressing here about staff work environment. So having said that, I think we need to acknowledge that, and you mentioned that, Heather, that incivility, workplace incivility among staff could be associated with the stress level and their quality of interaction with residents, and also residents' own anxiety and agitation and responsive behavior that would impact staff stress level. So there's some interesting connections potentially to be made, some direct between the quality of the physical environment and staff experience, and some more mediating associations, relationships through the residents' experience. So I'll just share a few thoughts here. One is, and some of this is coming from some anecdotal experience, some of it is some of the studies we have done comparing a more traditional long-term care setting, so 50 plus units, resident unit, versus a small household. That's what we call small houses or household, which are 10 to 12, 14 residents units. So, and there are quite a few studies done in the US in the Greenhouse Project, looking at the small household model's impact on not only residents' quality of life, but staff quality of care practices and so on. So one is again, the household size is critically important about, in terms of providing support for the residents, but also for the staff. And I'll just throw out a few things that are potentially relevant here. One is the quality of stimulation. We talk about environmental stimulation, which comes from high noise level, high lighting, institutional lighting, furnishing everything. We know these do impact residents' anxiety, but these could also impact staff as well in terms of the quantity and quality of stimulation they're taking in and day out. So imagine working in a very traditional long-term care setting as a staff versus working in a very small scale household. The stimulation level is quite different, and this is an accumulative effect over time. The second thing is what we call about the behavior setting idea, that we get our cues of what we want to do in terms of behavior through the setting. So we talk about in the context of people with dementia that they are very sensitive to environmental cues. And I think one could argue the same thing would apply to staff, meaning that, am I working in your home, or this is my workplace and I'm caring for you? right? So that kind of a psychosocial attitude and perception could be different when you talk about staff working in traditional long-term care units versus a more small scale household units. Another thing that is about staff break rooms, or what we call about where they can take a break, and that's an interesting area, which is from architectural standpoint, it's neglected. We just have a basement where people can go and spend some time during their breaks. So it's not a purposeful, it's not high demand. It doesn't get much attention from design perspective until recently. So that's something we would argue that there's a possible connection between different kinds of staff break spaces and that impacting staff interaction or not. Another thing is about coming back to household is that the group size for staff. So if we think about like how many care aides are interacting with each other, and I have a question about that, Heather. So does that make a difference? So if I'm a care aide working with 10 to 12 other care aides and nursing staff in a large care home, versus in a small household, I'm interacting with a fewer number, 4 to 5. Does that make a difference that I'm less likely to be incivil? And the last point I would say is about the issue of speaking of design is a shared room versus single rooms. So we know that shared rooms have impact on many levels in terms of impacting residents' sleep quality, visitation by family, as well as incivility and aggression within residents. So on the other hand, we know that there's evidence about how staff have better quality of interaction with residents in single rooms versus double rooms. So I wonder about that, and that's about, one could connect that might be a mediating factor about contributing less or more to staff's anxiety level. So these are a few thoughts that I have about some possible direct impact on staff stress and interaction with each other, and some are more mediated through residents' anxiety and functioning challenges. So I do have a question for Heather, if I may ask.
Mm-hmm.
My question for Heather is about the issue of staff. You talked about the demand for work. It's a very high demand work, and they're stressed and so on. What are your thoughts, or did you see any relationship with a comparative perspective on an environment A which has less stress? So speaking of stress, if you look at in a quantitative perspective, stress as a concept, high stress versus low stress environment impacting civility.
Yeah, really like that question, Habib, and it's a thought-provoking one. And I think the sites at which we conducted the research were similar. But I think to answer that question, I would probably reflect on my time working on the front lines. So when I was working on the front lines 25 years ago, and we look at if someone called in sick, we rarely worked short. Like I don't actually remember. Like it would be a really rare occurrence where we would be working short on the shift, and everyone was collegial and keen to come to work. And we never thought we were working in the golden era. Jennifer, when you think back to that time, that was a time when staff were well paid. There was time for education, and you were replaced if you were away. And fast forward to when I was doing this research, and there were times when I would walk into the second home in which we were doing the research, and on the board that would list kind of who was on that afternoon, there'd be one name, and that was it out of a unit that had sort of 25 residents, and so there were 2 spots that they needed to fill, and then that meant that someone stayed late, and so those demands that were placed upon the staff, right? So and then if staff felt that a staff member was taking too much time off, or happened to take a day off and then posted a picture of themselves on Facebook at a Canada Day parade, as opposed to, you know, lying on the couch, then staff are that much more sort of resentful, I think, when that staff member comes back, because they're not replaced. So that staff member who takes that day off is then punished because we just don't have those health human resources that we had previously. So I don't know if that answers your question a little bit, but I think those demands, a lot of it comes from, you know, who we have, are we able to fill shifts, and we just don't have the bodies. It'll be interesting to hear. I know, you know, there's probably a number of folks on the call who could probably, you know, speak more to that. So.
Thanks, Heather, for your thought on Habib's question. Amanda, would you like to share your thoughts on your question?
Sure. Yeah, so thank you, Heather, for your presentation and for drawing attention to this work. I'm going last, so a number of the points that I want to bring up have been raised, but I think in a slightly different way. So one of the, what I really appreciate about this work is drawing attention to how power relations are operating in practice in a really complex setting that, as Habib mentioned as well, is a workplace, and it's also a home. And I think that's a piece to really be the tension to be holding on to. It's both and, right? It's not either or. It's not just a workplace and it's not just a home. And so that, to me, is this important piece for trying to figure out what to do about it. And that's where the question is that I want to go towards. I have a couple of other pieces to bring up. So I really appreciate the toolkit as well as an instrument of change, right? So it starts if, you know, on some level, the research is really just starting this conversation, and then the toolkit kind of keeps that conversation going in a different way. And the piece I'd like to raise in this is that it links with the societal questions that maybe we should be having that are really about, like, what does it mean to care for each other as a society, for, you know, to give and to receive care. So we often talk about good care, you know, what is good care? And that might be a principle, but what also is what are the kind of human aspects of care when we're met with vulnerabilities? And so, you know, I'm often looking at the side of older people and the way that people get excluded within systems or by systems, powerful practices. And so this is another example of how both the workplace staff are being excluded from each other, you know, and I would imagine that also the residents are being excluded because you don't also want to be engaging in conflict. You know that there's a conflictual staff relation happening. And so how is that maybe furthering your exclusion? So the piece I would like to think about is about care, vulnerability, and power. And I guess it extends beyond your research. So you may not really have the evidence to answer it, but it's really like, how did what you saw, how did you kind of imagine that affecting older people's lives and vice versa, right? And how maybe does the exclusion of older people in neglected spaces like long-term care also further the power dynamics of who gets recognized, you know, whose lives are valued and who should be kind of respected. And so you see all of these dynamics. But what did you see? How can you imagine what you were seeing was affecting older people? And in some way you started there when you said, oh, the person came to me and said it was like this. But that's the question I have for you. Yeah.
And you know, it's such an interesting question. And I think you really nail it, Amanda, when you said how complex the situation is. There's a lot of pieces at play, and you know, we didn't directly measure the impact on the residents, but you could sense that in those observational like occurrences, right? So as you're witnessing care and you're witnessing how in a time where staff are working together, where there's that good working relationship, that collaboration, and how the resident sort of is more relaxed in that situation. And I can think of an observation where a resident was having their incontinent product changed, and the staff were bickering back and forth around how it should be positioned, and what it must feel like to be caught in that back and forth. And at that point, the resident was in their wheelchair. But if you think about how we care for residents, and we often we use mechanical lifts. And so then if you're starting, staff are getting into it, and someone's in this real position of vulnerability, you're partially clothed, you're suspended from the ceiling, and that tension that you might feel. So not something that we necessarily explored, but I think would be a real avenue for future, because I think that's part of it. As Habib said, we know that the best line to having contented residents and good quality of life for residents is ensuring we have good quality of work life for the staff. And so you would intuit that there is this relationship there, and how do we protect that vulnerability of residents. And I think about your comment about whose lives are valued, and that caring work that's done, and the work that folks on the front lines in our long-term care homes do is incredibly hard to begin with, and then to have to layer this on top of it makes it even more challenging. How do we make it so that we extend that same compassion that we extend to the residents to each other, and create those supportive workplaces? Yeah.
Well said, Heather, and thanks for that question, Amanda. Now we'll get into the next part of the panel discussion, where we ask a bit more specific questions to each of the member. Back to you, Jennifer. So they talked about highlighting these profound impacts of caregiving dynamics on the well-being of staff and the residents. So giving your experience in caregiving dynamics, I just want to know what your thoughts are like. Do you think it's likely that this workplace incivility effects extend to residents' well-being and quality of life and care directly and indirectly?
Oh, absolutely. So I think, we always think of, and Habib has mentioned this and others, Pat Armstrong's words, the conditions of work are the conditions of care. And of course, it's impacting resident care. It's impacting residents when people are bickering over the top of their head because, you do this, you do that. And I know there was other examples from Heather's work, and that goes back to the built environment, where we now have environments where we don't have call bells. So everybody's holding a phone. So there are staff that just turn off their phone and just don't respond. And then you really are working alone on your shift, right? So some of the things that we've done that we think are wonderful and are going to create certain outcomes are having other balancing types of outcomes that are quite negative. So I absolutely think that this is an issue. And I think as researchers who are doing workplace research, a lot of focus has been on staff burnout, staff empowerment, and maybe it's time to start asking staff about the context of bullying and incivility in their work, and being able, certainly with some of our big data systems, to be able to start doing some analysis looking at what is the direct or indirect impacts of levels of incivility in your workplace on resident outcomes. Because I think that we're there from a research point of view, but it's really thinking about collecting that kind of data that would be allowing us to look at those outcomes more clearly.
Great, thank you for that answer, Jennifer. And I would like to, perhaps ask Habib the next question. So you've listed out some of the factors in the physical environment that may may influence or impact the outcomes in work and living environments. I was just wondering, what do you think future research programs could look like? Kind of picking upon what Jennifer had said at the end there, with future research possibilities. She touched on upon noise, and I was just wondering what your thoughts are about that.
Yeah, I mean, there's so many areas of research that we can talk about. Maybe we'll touch on a few. One is, well, some of the things I mentioned earlier, would each of them be a research direction or research focus, but a few things that I will point out. One thing I have not mentioned in specific terms is again, talking about innovation in long-term care, especially in the environmental context, we talk about the value, and we have quite a substantial body of literature on which documents, which evidence on the impact of positive impact of small households, which by small I'm talking about 12 to 14. We talk about 12 being a limit at this point. There's a good optimal size on the quality of the residents, but we don't have much on quality of care and staff quality of life. But the other thing is a broader context about staffing models. So what I'm referring is that how many, when we talk about when we deal with or interact with organizations who are thinking about building a new care home, and we say, okay, these are the evidence about that small care homes can help residents' quality of life, and they would say, okay, this sounds good, but operationally it's complicated. We may not be able to move this forward in terms of operational, in terms of how the staffing model works. So we really need to have some research looking at this disconnect, this gap between small household and appropriate staffing models. So, by staffing model, the staff resident ratio, and then whether there's universal worker model, whatever the model might be, with the household model that could work. And I would extend that to our topic today is, do these innovative staffing models, and in conjunction with a small household setting, could potentially affect incivility and more better teamwork or so and so on. So that's one area. Another area is the more specific term is about staff workspaces, and we kind of touched on that. So staff workspaces traditionally included like a big nurses station. So that is kind of a legacy from the acute care model. But again, if you look at the innovative newer models, we talk about moving away from those architecturally prominent nursing stations to a more workspaces that are embedded in the social spaces, part of a living area, part of a kitchen, and so on. So the question becomes, this approach does create a more home-like setting, but how does it affect staff communication interaction with each other and their quality of work, the charting and whatnot? So I think I would like to, I think that would be an interesting area to look at. And finally, what we talked about earlier is about the residents' quality of life, functioning, responsive behaviors, and so on, impacting staff stress and potentially impacting incivility, that those connections could be carefully looked at. So, and I think the issue of stress or workload from, or maybe we would put it this, the quality of care given by staff to residents, to what extent that is impacting incivility and vice versa, to what extent incivil behavior is contributing to stress and contributing to quality of care. So, but that's not an environmental question per se, but that's a research question that we could also pose. But I think I mentioned a few other environmental issues, and also wayfinding is an issue as well. We know spatial navigation is a problem in many care homes where staff need to help residents mobility in the morning from their home, from their rooms to the social spaces, and then also in the afternoon sometimes, and how these impact staff workload and so on. So I think that's some interesting areas to look at more directly on environment's impact on staff interaction with each other and potentially incivility, as well as through the mediating factor of residents' quality of life.
All right, thanks, Habib. So my next question will be to Amanda. Given your perspective as a social gerontologist, how do you understand Heather's presentation and research in light of your own expertise and in research across care settings, and in particular in the marginalized groups?
My research started on frailty, and it was always about how older women, it was social constructs of frailty. So how women were labeled as frail and didn't necessarily understand themselves as frail. And frailty ended up being a lot more about both structural relations, like the power, kind of the gendered dynamics, immigration, migration issues, and the interpersonal piece of how they felt when someone stigmatized or excluded them for being frail. And so, you know, Heather's presentation has drawn attention to the extent to which these structural macro issues are playing out of discrimination and often migrant status, you know, are playing out in this micro kind of setting or case of institutional or long-term care. So I think the piece to keep coming back to is not to lose sight of the larger structural, societal, and global. We haven't even mentioned the global pieces about global migrant care chains, et cetera, that people are often kind of coming here and then caring transnationally. So not to lose sight of that, but then to also think about that interpersonal bit about emotions. And so thinking about trauma, so that, you know, workers are bringing trauma, residents are bringing trauma, and those are related to the systemic injustices. So looking at the emotion, that's why I thought the card piece, it's one, the cards that you had at the end were one really interesting example. If we think about the question of knowing that we have these systemic issues, how do we foster good civil human relationships between workers, staff, clients, everyone, right? Older people themselves. And that was a really good example. It's one example, and there might be others. And so we need to start asking people, what would feel better? You know, what would make your work or your day feel better? And people know that, and they're really often small things. And this is maybe where there are links with some of what Habib was talking about the physical environments. Maybe it's music, maybe it's, I just want someone to say hi to me, or I want them to know where I came from, or I want them to know what my, you know, what my daily life looks like. You know, I'm a worker and a person, right? A human. So that's what I would kind of wrap up quickly in this, and is continuing the conversations. Yeah.
Great. Thank you so much, Amanda. And now over to you, Whitney. So the work that Heather and her colleagues highlights the micro and meso level interactions within organization. Given your expertise in organizational behavior, how do the observations made by Heather and her colleagues sit with respect to this broader macro level of human health, human resources issues that we have in the long-term care sector?
Yeah, so I'll put on my org behavior or work psychology hat for a moment. I mean, we've all talked about, and Heather began with talking about the long-term care sector and the shortages and the turnover and difficulties in recruitment and the burnout that is now so evident. And you know, others have highlighted long-term care as kind of the sector of last resort, right, for some workers. Unfortunate, but I think true. What might be done? I mean, people, to Amanda's very good point, I mean, people are people. You know, long-term care workers, I think, are motivated or demotivated, just as any other workers are in their workplace, right? They're human. They have needs of their work environments, not just financial security, but they have needs for self-actualization. They have needs for safety and a sense of support on the part of their workplace. They have needs for knowledge and for personal growth. So I think we need to acknowledge that. I think that's a huge step. It sounds odd, but I somehow, for some reason, I simply don't see that kind of conversation really in this sector in particular. I think we need to recognize the linkages between workers' attitudes, how they feel about their work, how they feel about themselves, and their performance, and worker outcomes and outcomes in this instance, in this particular context, as it relates to the people for whom they care. And think about incivility and psychosocial and environmental impacts on things like work motivation, work attitudes, work performance, worker mental health and well-being. Bring all that together. You know, as has been done in many other industries, there's an abundance of research that's situated in organizational behavior broadly, but it's, you know, it engages organizations in multitude of industries. And why couldn't this work be applied to thinking about, you know, the concerns and issues and challenges of these workers in particular? Job mobility. Think about job mobility in the long-term care sector. No one gives a thought to that. No one thinks about progression, right? Progressing in one's career, whether you begin as a healthcare aide or a nurse, you know, in a long-term care facility. It's so very interesting that this has been completely overlooked. And then I think you were going to ask me about innovation, shall I? Right? And how, just not that we choreographed this at all, but we did talk about some of the topics that we might cover. So, you know, and I think about, you know, what Heather was saying in her presentation. I couldn't help but think, oh my gosh, think about how profoundly this kind of work environment must be influencing not only individuals and how they feel, how they behave, the kinds of behaviors that they decide to exhibit or not, pro-social behaviors, extra role behaviors, you know, the kinds of things that are outside of one's role, but, you know, going that extra mile for their residents, you know, those kinds of behaviors and lead to innovation. And in these kinds of environments, which are not environments that one would describe as, you know, environments of positive affect, that's the term that folks in the OB world use, as you know, they're not happy work environments. In these kinds of environments, there is very little demonstration of those kinds of behaviors that are extra role that lead to innovation. So think about that. That's a profound, you know, potentially profound finding, that in fact this is a suppressive environment in which innovation is not occurring, or it's, you know, it's just occurring in spite of all these suppressors. And in fact, it's these kinds of negative work environments also lead, the literature says, to withdrawal of behaviors, right? Not only withdrawal of extra role behaviors, but withdrawal of in-role behaviors, you know, absences, things like this. And, you know, this is an understandable human, workers are workers, people are people, human response to negative environments.
Great, thank you, Whitney. And thank you, panel, for your discussion on this topic.